emergency department for exacerbation. And for emergency management of bronchial asthma, it is very essential to know the severity, degree of severity of the bronchial asthma. So, severity of bronchial asthma. Bronchial asthma. This is the A1. Means emergency management. First segment is severity of bronchial asthma. This is very important. And although there are different grades but for practical point of view, there are two major grading of severity. But I will tell all of them so that you will have a better understanding. Mild, moderate, severe, life threatening, means mild asthma, moderate asthma, severe asthma, life threatening asthma, and near fatal asthma. In near fatal asthma, patient cannot live without ventilatory support. So, from practical point of view, these two are same. From practical point of view means from management point of view. Management of mild exacerbation of severe asthma or moderate exacerbation of exacerbation of asthma will be the same. And this one and these three from management point of view are same. Okay, these will be pharmacological. These will be dealt with pharmacological management, and these will require pharmacological management, and in addition to that, non-pharmacological management. Although non-pharmacological management is also here, but that is different. I will be telling later on what is difference between non-pharmacological of this one, mild and moderate, and non-pharmacological management of this one. Non-pharmacological management. And this one also consists of pharmacological management and non-pharmacological management. These are headings and systematic things just for teaching, but after class will be over, you will be having a very clear picture. I believe that you shall have a very clear picture of what to do in emergency and what to write in prescription while you are discharging your patient. So, flow or forced expiratory volume in 1 second. FEV1 जिसको हम लोग कहते हैं forced expiratory volume in 1 second. How much he is able to exhale in 1 second after forceful effort. And if that FEV1 is between 50 to 75%, sorry, 75% to 100%. Somewhere between 75 to 100%. It is called mild exaggeration of asthma. If APV1 is between 52% to 75% of what? 50 to 75% of personal best or predicted. There is predicted value of APV1, that is a standard value, or personal best. If APV1 is 75% to 100% of his personal best or the predicted value, then it is mild asthma. Actually it is mild exacerbation of asthma. To be exact, we are dealing with exacerbation of bronchial asthma, because bronchial asthma patients are stable and they don't come when they are stable. They come to you only when they face exacerbation of asthma. So this should be very clear, because asthma patients are usually asymptomatic. And if APV1 is between 33% to 50% of predicted or personal best, it is called severe asthma. Severe asthma, and in book by convention it is called acute severe asthma. Although there is no need to tell that it is acute severe asthma, because whenever there is exacerbation it will always be acute, but it is somehow a convention to call it acute severe asthma. And when it is less than APV1 is less than 33%, it is called life-threatening asthma. Life-threatening asthma. And when patient cannot survive without the help of ventilatory support, it is called near fatal asthma. Near fatal asthma means when ventilatory support is must. I should repeat once again, because many people have come late, but this should not be the habit from the next time. We are dealing with the management of bronchial asthma, but to be exact, it is management of exacerbation of bronchial asthma, because bronchial asthma patients are stable and they come to you only when they face exacerbation, and we are dealing with the management of bronchial asthma exacerbation. And there are two kind of management. Emergency management of bronchial asthma. For the sake of convenience, I will telling just bronchial asthma, not exacerbation of bronchial asthma, because it takes more time and effort. So emergency management and management at the time of discharge of the patient, because there is a fundamental difference between the two, which we miss, but from now onward we will not miss it. So first part, we are dealing with first part, emergency management of bronchial asthma. To deal with the emergency management of bronchial asthma, we must know about the severity of the asthma, because that has linked with the management part itself. So in that connection, I was telling that there are mild, moderate, severe, life-threatening and near fatal asthma. And why? And after that, I clubbed mild and moderate together, because management is same for mild and moderate asthma, and severe, life-threatening and near fatal asthma management is more or less same. That's why I clubbed them together, about which I will be telling later on. So now we have come to mild and moderate. After that, I was telling how it is called mild, moderate, and severe and life-threatening and uh, near fatal asthma. So this is the thing. Although in emergency department we are not having the facility to measure the forced expiratory volume, so we have to develop a practical way of knowing whether it is mild, moderate, or severe. If we are not dealing with a severe exacerbation of bronchial asthma, then automatically we are dealing with mild or moderate uh, asthma. Therefore, we should know about what is the symptom and how we can assess that we are dealing with severe asthma, this one, because its management is different from mild and moderate. So we must know about what is called severe asthma. I want to tell you that mild and moderate asthma has two parts. One is pharmacological part, pharmacological management, and another is non-pharmacological management, which I will be telling what is the importance of these things. And therefore we should know about how to differentiate between. So for practical point of view, we should have just two grading in our mind, that is whether it is severe or mild moderate. And there is no means to know about mild and moderate, so we have to rule out whether it is severe asthma or not. So the features of severe asthma, and in book it is also written as acute severe asthma, but that is just a fancy word, because exacerbation will always be acute. So severe asthma will be characterized by first respiratory rate. Respiratory rate will be, these are practical things which we can do in emergency. Now, from now onward, everything is practical. That is not that much theoretical. Respiratory rate more than or equal to 25. You can assess it. Pulse rate, or what you call heart rate. Pulse rate is more than or equal to 110. Inability to complete a sentence. You may ask how many children you have, or tell me about whether how you are feeling, and in that process he or she will tell you something, and you will find that his breath is catching in between. In case he is unable to complete a sentence and his respiratory rate is 25 or more than 25, pulse rate is more than or equal to 110, and he is unable to complete a sentence. This is a very simple thing which you can do very easily. Just 3 points. You can easily assess whenever it is severe asthma, then its management slightly changes, and when it is mild or moderate, its management is slightly different. What is the difference? I should tell at this point. In mild or moderate asthma, you need just short-acting beta agonist, which is salbutamol, which we use salbutamol. And in severe asthma, we have to add either oral or IV corticosteroids. inhaled corticosteroids we give in many emergency department, but that is not recommended thing. That is a major difference from now onward, because that has significance. That is controversial. Inclusion of inhaled corticosteroids along with oral or IV corticosteroids is controversial, and in severe asthma you will have to give oral corticosteroids, and if patient is not able to take oral corticosteroids, you will have to give IV corticosteroids, and inhaled corticosteroids is given at the time of discharge. But there are some practical difficulties which arises, which I will be also telling about, and how to solve those difficulties. And let us come to management of mild and moderate exacerbation of bronchial asthma. Mild, moderate asthma. Most of the time we do this one, and some cases also come very severe. And I have told you how to assess the severity: respiratory rate, pulse rate, and inability to complete a sentence. If you are not, if you are not in hurry, an emergency department, one is pulling your hand in this direction, another is there pulling in this direction, then in that case you should simply ask for complete a sentence. That should be a tool in your hand 24/7. How to assess severe? If you forget pulse respiratory rate more than 25 and pulse rate 110, then at least you should be clear. If someone is unable to complete his or her sentence, he is severe, he is having severe asthma. And only difference between mild and moderate and severe asthma, that he or she will require either oral or IV steroid, not the inhaled steroid. Inhaled steroid is for stable patients at the time of discharge. This is a major departure from our practice till now, and I will be telling how the duoline and budecort and all these things are make it, how to make some improvement or amendment. And before this, I will tell you the composition of duoline and budecort that we do, that we use, and how we can do what I am telling now, because that is recommended one, and we should do a standard practice. What is written in book, because this is how we shall be different from the quacks that are practicing outside, because they do know Foracort and Livolin, but they don't know how and when to use. So this is duoline. What you use duoline and budecort. Duo means there are two things in this one. This comprises of salbutamol, and another is ipratropium bromide. This is the combination of these two things. This is duoline is salbutamol and ipratropium bromide. I think we should open this one because there is no AC and therefore we are fixed. Salbutamol and ipratropium bromide. And what I am telling now, that management of mild to moderate asthma requires just this one. Mild to moderate asthma requires just this one, salbutamol. Then how you will be getting salbutamol, because I know you people must knowing just about duoline and budecort. So pure salbutamol comes in the name of asthaline residue. Asthaline residue. From now onward, you people will assess the severity, and if your patient is having mild or moderate asthma, you will ask for asthaline residues only. Asthaline and it comes in the strength of 2.5 milligram per SPU. 2.5 milligram, and exactly the dose is also 2.5 milligram to 5 milligram. So we can start with this one, 2.5 milligram. 2.5 milligram as management of mild to moderate asthma is inhaled asthaline, means asthaline 2.5 to 5 milligram given at the interval of 20 to 30 minutes. For practical purpose, keep it 20 at the interval of 20 minutes for 3 doses. This is the management of mild to moderate asthma. By just giving 3 doses of salbutamol 2.5 milligram for 3 doses, he or she will be relieved when she or he will be having mild to moderate asthma. So you can ask for asthaline rescues. Okay? If the patient is not responding to this one, so because we don't have FEV1 at our hand, which we cannot do, peak expiratory flow meter is not available here. So if it does not respond after 3 doses of asthaline 2.5 milligram for 3 dosage at the interval of 20 minutes, that will become for over 1 hour period, then you should go for the management of severe exacerbation of asthma. So I should go to management of severe asthma. So there is only one, you should write one point, management of mild moderate asthma, inhaled salbutamol 2.5 milligram to 5 milligram. Either you should use 2 rescues will become 5 milligram, asthaline rescues 3 doses at the interval of 20 minutes, and that will take care of your mild moderate asthma. If that is not responding, it means that it also becomes evident that it is a case of severe asthma, and for severe asthma we will have to do something more than this. Management of severe in severe asthma also, when you delineate from the first point, that is patient's pulse rate is more than 110, respiratory rate is more than or equal to 25, and he is unable to complete his sentence, then it is severe asthma. In severe asthma also, you will have to start with the ipratropium, salbutamol, because this is short-acting beta agonist. So this will give instant relief, definitely, but that will not relieve his entire spectrum of symptoms. So the first management will be inhale salbutamol. This is asthaline. Asthaline rescues. Asthaline rescues salbutamol. 1 to 2 rescues. 1 to 2 rescues at 20 minute interval. For 3 times, and this will go in hand. We will not wait for when we have already assessed that it is severe asthma. Then we will give salbutamol, and simultaneously we will start oral or IV corticosteroids. If patient is able to take orally, we should give, and if patient is very dyspneic or unable to take it, very irritable, because severe asthma is on the ground, it is very agitating for the patient. So we will give corticosteroids. So how to give corticosteroids? Oral corticosteroids, oral 1 milligram per kg body weight per day. Practically in our part, patients are usually of 50 kg. So you can take it as 50 milligram prednisolone, which comes under the by name of visolone. You must have learned visolone, visolone tablet. Usually it comes in the dose of 5 milligram, 10 milligram, and 20 milligram. So if you have to give 50 milligram, you will give 20, prescribe 20 milligram tablets, and you will have to give 2.5 tablets to make it, or IV steroid. IV steroid. This is 50 milligram hydrocortisone. Either of the two, not both. Either oral means you have to give inhaled salbutamol in severe asthma, and number two, you will have to give oral. You have to give a steroid, either oral or IV, not inhaled. IV steroid 50 milligram hydrocortisone, cortisone 6 hourly. This is about short acting beta agonist and steroids, and we have to sometime give adrenaline or epinephrine in case the exacerbation is part of the anaphylaxis or angioedema. So then how you will be many times, because asthma, exacerbation of asthma is because of allergens, and many times allergens cause anaphylaxis or angioedema. Anaphylaxis is acute severe immunological reactions, and we catch anaphylaxis or angioedema by swelling, abnormal swelling of lips and face, and that also leads to bronchial edema, and that's why patient becomes very much restless. So that should also be in our mind. In that case, we give epinephrine also. That is adrenaline, epinephrine, and adrenaline. All the three are one and the same things. So epinephrine in severe asthma. One thing I should tell. In severe asthma itself, we should give epinephrine, even it is not anaphylaxis or angioedema. And there is slight difference in giving epinephrine. We have here 1 ampule has 1 milligram of epinephrine, 1 ml. So you will have to, at times, you have to apply your own common sense. So how much to take from it and give accordingly. You will have to do approximation also, because sometimes in our medical science, the actual dose and the packaging of the products is such that you cannot do it in a linear fashion. For example, if you go through the books for a scorpion bite, the dose of prazopressin is 0.5, starting from 0.5 milligram to 2.5 milligram, 1 to 3 hourly. But do we have any 0.5 milligram tablet of prazosin? No. And it is very difficult to make a 2.5 mg tablet and separate from that 0.5 milligram. So, but you will have to do it, because this is the way the things are on the ground. On the ground, we must have to do certain adjustments and readjustment to survive. That is true for all parts of life, whether are practical or theoretical or personal or social life. So epinephrine in severe asthma, we will have to give epinephrine, and that is given subcutaneously. Subcutaneous epinephrine subcutaneously, and how much? It is 0.3 milligram. 0.3 milligram epinephrine or adrenaline subcutaneously. So we have three things. These are three major things that we give in the severe asthma. And in case of angioedema or anaphylaxis is abnormal swelling of lips, and patient will be almost gasping because of bronchial asthma, bronchial edema. Then in that case, we give IV mm, IV epinephrine, and for that we should give. This is the usual part. In severe asthma, we will have to give it routinely, and in case of anaphylaxis and angioedema, IV epinephrine, and that is 0.5 mg. 0.5 mg. 0.5 mg will be easy because that 1 ml ampoule contains 1 milligram of epinephrine. Then taking half of that will be very easy. So this is, and besides this, there are other supportive medications. Supportive medications which we can use in the management of severe asthma, and they will come. 0.3 mg or IV 0.5 mg. Actually, to be exact, I didn't tell per kg weight just to avoid confusion. Actual dose in anaphylaxis or angioedema is 0.01 per kg body weight, but that becomes cumbersome. But it is also written from that up to 0.5 mg. So I simplified it, just give it 0.5 mg, because many times you cannot assess this one. A 16-year or 17-year-old girl will be very light in weight than a 60 or 20. So you can give this one, because in life-threatening situations, epinephrine up to 1 milligram is recommended, whose dilution is 1:1,000, which is available here. So epinephrine in severe asthma, you can give subcutaneously when just severity, but there is no anaphylaxis or angioedema. And if you suspect anaphylaxis or angioedema, like swelling of lips, swelling of face, abnormal swelling all of a sudden, then you should know it is angioedema or anaphylaxis, and in that case you will have to give IV epinephrine 0.5 mg. And other medications in severe asthma which we can give: number 4 will be anticholinergic drug, which is called, we use ipratropium bromide. This is not required in mild to moderate asthma. That's why it is necessary to know about these things separately. Anticholinergic drugs are needed only in severe asthma, and it is a ipratropium bromide. It comes under the name of Ipravent rescue. Salbutamol is asthalin rescue. It is Ipravent rescues, and it is in the strength of 500 microgram, and that 500 microgram is given 4 to 6 hourly. And that's why another important point is that if you are not sure about severity and all that, you don't know anything, and even in that case you should know this much, that ipratropium bromide is given 4 to 6 hourly. So even when you give Duolin and Budecort, so it should not be 8 hourly prescription of asthma. It should be at least 6 hourly, and better it would be 4 hourly, because ipratropium anticholinergic drug too has importance in case of severe asthma, and many times we see severe patients. So always get the habit of, if you write duolin and budecort even now onwards, then you should write it 4 to 6 hourly or simply 4 hourly, because after 4 hours this ipratropium bromide will lose its action, and in severe asthma it is necessary. And one more thing, uh, that is important in severe asthma, magnesium sulfate. 2 gram magnesium sulfate over 20 minutes. One dose. One dose of 2 gram magnesium sulfate over 20 minutes. What it does? It reduces the uh, hospitalization of acutely severe patients in future. This has some importance. So these 5 things should be used in moderate severe asthma, anticholinergics, and magnesium sulfate 2 gram over 10 minutes. So these are the pharmacological managements of uh, management, which I told about: mild, moderate, and severe pharmacological management. Now we should also know non-pharmacological part. Uh, Non-pharmacological part is actually needed in severe asthma. In mild, non-pharmacological part is common one. And what is that one? I should tell. You should read from the book, because this is a practical class. That's why I am telling just what we can do in emergency department. Magnesium sulfate has another mechanism in your eclampsia, and in respiratory system it has another mechanism. And this is not a theoretical class. We are dealing with just practical part. Although you should do it, because that might be asking your NEET examination. So time here for common purpose and for our patients. Pharmacological, non-pharmacological management of asthma. Non-pharmacological part, we take fluid management. You should know whether it is hypotension or not. Actually, I should be telling about the features of life-threatening asthma. So, life-threatening asthma, one of the features of life-threatening asthma is hypotension. Another feature is FEV1 in life-threatening asthma is less than 33%. PO2 is less than 8 kilopascal. Patient will be cyanosed. He will have very reduced respiratory effort. His chest will be silent. He will appear exhausted, and he or she will be having hypotension. So these are the signs of life-threatening asthma. Cyanosis, silent chest, these are very important things. Hypotension. In that case, we will have to take care of fluid management. So it is non-pharmacological part is also important. Fluid management and electrolyte management. Why electrolyte management? One thing that I did not tell at the outset, when we give salbutamol, then salbutamol has one side effect, it causes hypokalemia. And when we give salbutamol, we should do ABG specifically to look after whether, especially when you are going around in the emergency department and patient is admitted from 2 days on 8 hourly or 6 hourly dual in Budapest, you must check his or her electrolyte report to rule out hypokalemia, because hypokalemia too can be dangerous if left untreated for long. Electrolyte management and fluid management, these are non-pharmacological management of uh, 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 asthma. And another part, non-pharmacological part is for uh, uh, moderate to severe asthma. Moderate to severe asthma, we need at times non-invasive positive pressure ventilation like BiPAP or CPAP machine. And for life-threatening or near-fatal asthma, we need invasive ventilation, means endotracheal uh, intubation and ventilation. So that is the non-invasive positive pressure ventilation. This is for mild moderate asthma. And in severe to life-threatening and near-fatal asthma, we need ventilation, actual ventilation, invasive ventilation after doing endotracheal intubation. So this is the thing. This is the emergency management. I think you must have got some point, and after that I will be summarizing later on entire thing to make the entire forest clear, because when we talk about a forest, we talk about one tree at a time, but forest in completeness is much simpler than a simple single tree. So is this one. Management at the time of discharge. This is very important, because ultimately patient well-being will be decided by this one. Inhaled steroid is given at the time of discharge. So inhaled steroid and 5 to 7 days and oral steroid. Inhaled steroid and oral steroid. This is must. This is not to be missed. How much? 5 to 7 days of oral steroids, dose being 1 milligram per kg per day, but it has its limitations. If you have somebody who is 100 kg, then you cannot go for 100 milligram steroids. Up to 50 milligram per day. Means you will have, if some young girl is just 40 kg or 25 kg or nearly 20 kg, young girl, then you have to give 20 milligram, and maximum you can go for 50 milligram per day. And this oral steroid for 5 to 7 days has to be covered with inhaled steroid. If you will not give this one, then this inhaled steroid will not be able to make him or her stable, because this oral steroid is much more effective than inhaled steroids. And one beauty is this one: when you give oral steroid just for 5 to 7 days, this does not require tapering. This does not require tapering of the dosage, because we have already learned that high dose means a steroid demands tapering. It cannot be stopped all of a sudden. So even if we are giving 50 milligram per day and just for 5 to 7 days, we can stop it altogether all of a sudden. And this is inhaled steroid, oral steroid, and here you can take the pure steroids like budesonide or budecort, like that. Budecort is used. So this is the ideal treatment. You have to give inhaled steroid and as well as oral, and this is the best way to manage the bronchial asthma. Now you can ask questions because I believe. Let me tell some another points which I didn't tell at the outset, just to make the things simpler. You should know about the features of life-threatening asthma, which I have just told, uh, and I should write it down on the board so that it gets the gravity. Life-threatening, because you should know, and when these features are there, first of all you should counsel your patients, and also you should go for ventilation, because if you just give inhaler or and other drugs and fluid and locrat, that is not going to make her condition better. When he or she is having life-threatening exacerbation of asthma. Number one, although we don't have this facility, APV1 whole expiratory volume in 1 second is less than or equal to 33% of the predicted or the personal best. उस व्यक्ति का जो बेस्ट है, क्योंकि आस्थमेटिक हो गया तो उसका 30%, उसका पोस्ट एक्सपिरेटरी वॉल्यूम बिफोर admission in hospital. So that is very tedious task to know what was his FEV1 before admission in hospital. That might be possible in UK, where from where our book is published. FEV1, PO2 less than 8 kilopascal, PCO2 is normal. What is the normal value of PCO2? Okay. Cyanosis. Silent chest. In auscultation, you are not listening anything. Silent chest. Reduced respiratory effort. Patient is not making any effort to breathe. Reduced respiratory effort. Patient looks exhausted. And patient is having hypotension. Whenever you see a patient of asthma and he is having hypotension, his blood pressure is not is unrecordable, pulse is very feeble. These can be very easily seen. Cyanosis. We cannot see this one. We cannot see this one. We cannot see one. But we can see this one. 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 Always develop a habit of getting something valuable as your tool while reading anything, because everything you cannot apply on the ground. And what you cannot apply on the ground, sometimes it becomes burden, because you will forget actual things. You can easily see cyanosis, silent chest, reduced respiratory effort, exhausted, and hypotension. These are the signs of life-threatening asthma. You should know why it is life-threatening, because if it will be not given ventilatory support, the patient will not is not going to survive. So you should go for ventilatory support. That is the significance of knowing what is life-threatening exacerbation of asthma. So this completes from my side, and if you have any, आप लोग अपना नाम लिख के दे देना था जो